Get started. We've got a big turnout today. We usually make a couple announcements. My name's Alex Sabo. I'm the chair of psychiatry here. We have a special, our state rep is here today. Vinny Pignatelli, stand up and say hi. It's wonderful to have you here. He represents us for many years in the legislature, advocating for resources for our county. It's great to have you here, Smitty. Thank you. All right, we have a couple announcements about departmental stuff. This is something that may be of general interest to people here today. On November 1, there is an educational program we help plan with Bay State. And Mary O'Malley is actually going to be talking about spirituality and suicide. At this conference, it'll be November 1 at Bay State. It'll be in the Bay State area. And the title of the conference is Understanding and Preventing Suicide Across the Lifespan. There'll also be a very famous geriatric suicidologist, Yates Conwell, will be there. And it'd be really worth your attending if you have a chance to do that. You can talk to Sarah if you're interested in learning more about that conference. Resident interviews for the new residents applying to our program will be coming up again in a month, and many of you helped in that. Thank you in advance. There's a depression screening day as part of our suicide prevention efforts. That's going to be on October 10th. This is free and confidential and open to the community for people who are interested in getting a screening for depression. Quarterly forums for employees are occurring. Any concerns, submit them to Jean Terrell and get those addressed by administrative staff. And then all employees are encouraged to attend Flupalooza on September 25 from 6 to 6. It's a hospital-wide initiative to get you vaccinated. Flupalooza. Don't miss it. All right? So that's what's going on. Today we have a really dramatic and important presentation that many of us are interested in for many different dimensions. And we have three outstanding speakers on the concept of medical marijuana. We have Dr. Jennifer Michaels, who many of you know, but just a quick overview. She's dual board certified in adult and addiction psychiatry. She is a national mentor for physician clinical support system. She's a SAMHSA that's a SAMHSA funded program providing training and education to physicians who are treating people with addictions and alcoholism. Dr. Michaels is a frequent guest on public radio. Many of you have heard her. If you haven't, she's a wonderful speaker and really kind of has a very thoughtful way of taking questions at just the right level. And she's a great tribute to our program, representing us when she speaks that way and helping the community. What else? Dr. Michaels is the medical director of the Breen Center and a proud member of the Berkshire Health System's medical staff. She's just an outstanding clinician, educator, and public figure, and she's very knowledgeable on this. So welcome, Jennifer. Dr. Michaels. And we have Dr. Harrington. Raise your hand. Dr. Harrington, you'll see, is a clinical psychologist who is a member of our team who does all kinds of interesting stuff in primary care outreach. He works in the area of anxiety disorders, pain problems. He's an expert in cognitive behavioral therapy. And he was kind of, the instigator of this. He said he wanted to kind of work this year on learning more about medical marijuana and I think help, then unite up with Dr. Michaels and John Rogers. So John's a kind of distinguished member of our faculty and a core member of our team here. John Rogers, if you don't know him, is the Vice President of Legal Affairs, in-house counsel for the health system, graduate of Yale, went on to Georgetown Law School, has done all kinds of cool things. He speaks for himself. He's also a literary man, if you don't know that about John. And so among the three of them, you're going to get as broad a perspective on this topic as you can find. I'll shut up and let them get going. So thank you.
thank you for coming today. John, and I have been meeting for a couple of months to talk about medical marijuana. It became clear very early on that we could talk to you for hours or days, but we're speaking to you for about an hour. So consider this a foundation from which further discussion hopefully will happen, because there's so much to talk about. So with that in mind, let's see if I can figure out how to go forward. First of all, what is marijuana? It's confusing if you really think about it. It comes from cannabis plants, and there are 3 varieties of cannabis plants, and I've put them up here. Ruderalis, if you go to Russia or the Midwest, you may look around and say, wow, look at all those marijuana plants. Those are wild cannabis plants with extremely low THC content. If you look at sativa, it's a much bigger plant. Human beings have been cultivating sativa for centuries to increase the THC, the psychoactive chemical. So if you think about cannabis plants and humankind, we think about sativa. Finally, another very important one is indica, and the reason that's important is it has other cannabinoids, other chemicals beyond the psychoactive THC. And you'll see in a little while why that's important. It has what's called cannabidiol, which is a cannabinoid that is not psychoactive. It does not get people high, but it may have therapeutic value. So there are 3 different cannabinoids. We think of marijuana as the product of these, but they're very different in a variety of ways. Okay. A brief history of man and marijuana. This is a burial site, and we know that when people get buried, they often put in important items for their afterlife, and that could be food, it could be weapons, bowls. This person had a lot of marijuana with him because he wanted to be prepared for the afterlife, and that's not unique to this burial site. So it's a long-standing relationship, 5,000 or more years that human beings have had a relationship with marijuana, whether using it for medicine, for ceremony, to have euphoria. It also is a source of food and a source of fiber. You can see hemp clothing, and it's not something people are smoking. It does not have THC in it, but it also it is used for food, for building materials even. We have a very minuscule period of research, of understanding the chemicals, the neurochemistry in marijuana, and so there's a real mismatch between our experience and our knowledge. Why is this? There we go. So the question again is, what is marijuana? Is it what this guy's doing, or this woman? Here's Sanjay Gupta, who had a special recently, weed. He visited a patient who I think was dying of cancer in Israel, but was taking aerosolized marijuana for medicinal value. Is it that little baggie that says for medical purposes only? It's probably all the above. Okay. What more do we know about marijuana? What is in it? It is comprised of at least 400 chemicals. Many chemicals, many we have not fully researched. There are antioxidants. We know those are good for us. There are carcinogens. There are amino acids. There are fatty acids. There are many chemicals, and many that we have yet to characterize. There are 84 or more cannabinoids, and I'll tell you what a cannabinoid is in a second, but cannabinoids are all like THC. Okay, THC is the one, or tetrahydrocannabinol is the one we think about when we think about marijuana. It's a cannabinoid, it's psychoactive, it gets us high, euphoric, it can make us anxious, but it's not the only one. There are many cannabinoids, and each cannabinoid has a unique profile of activity in the human body. We have a lot to learn, okay? All cannabinoids, this is the definition, simply. They bind to our endocannabinoid system. What's our endocannabinoid system? This simply means that we have receptors in our brain, and all cannabinoids will bind to these areas in our brain. All right? So, for example, THC, tetrahydrocannabinol, binds to our endocannabinoid or our cannabinoid system. And these are some of the effects. some beneficial, some not so. Remember, there are 84 or more of these cannabinoids. I'll just go through a few. Cannabidiol, I'm personally very interested in this because it's non-psychoactive, but may have some therapeutic effects. We need to do a lot more research looking at this specific cannabinoid. Another one, cannabinol, is psychoactive, is immunosuppressant, and the list goes on, and we're seeing things like anti-inflammatory, immunosuppressant, psychoactive, not psychoactive. So we don't really have a good gauge of the therapeutic applications and the potentially harmful applications. So these all bind to our cannabinoid system. There's a parallel here. Can anyone think of what this group is like when we think of other substances in our lives that come from plants? Opioids, exactly, because opioids for the longest time, thousands of years, we used opium, we used codeine, morphine. We had no idea what they were doing in our body. Sometimes it was therapeutic, sometimes not so much, right? And then only in the last 100 years or less, we started to realize we have our own opioid receptors in our brain. We have our own opioids, endorphins, that our brain makes, right? And that these external opioids were tapping into our internal, long in existence system. And the same is true for cannabinoids because, we have something called anandamide. How many of you have heard of that substance, anandamide? Can you just raise your hand? Okay, this is a major neurotransmitter in our brains, and most people have not heard of anandamide. I saw 2 or 3 hands go up. Anandamide, it was isolated by an Israeli group. It is named after the Sanskrit word for bliss, and it binds, it's our endogenous cannabinoid, endocannabinoid neurotransmitter, and it is, it's probably one of many. We have not isolated many endocannabinoids, but I think we will. Just like we started off with endorphins, then we found enkephalins. So this is a very young science. And the only other thing to show you is over here, this is what anandamide looks like, the structure, and you can see that THC is somewhat similar. Where do our body's cannabinoids bind? We think of the brain, but you should know that they're throughout our system. Lungs, liver, testes, ovaries. The red areas are the densest areas, but they're throughout the body. And just to complicate matters, we have cannabinoid 1 receptors, primarily in the brain, cannabinoid 2 receptors, which are more in the periphery. Okay, so think of all of those 84 cannabinoids, cannabinoid 1, cannabinoid 2. Really complicated. We know, I think, next to nothing. This I'm very excited about. We have cannabinoid 2 receptors in our peripheral body and the nerves, and this is a potential area, if I can get this to work, for pain control. Okay? So young science, we have a lot to learn, but there's a lot of good that can come out of it. These are the cannabinoid 2 receptors. Cannabinoid 1 receptors are the ones we think of when we think about THC and THC effects. This is a lot to go over, and we don't have a lot of time. Maybe I'll just mention a few things. So for example, if we start at the bottom of the brain, looking at the brainstem, there may be a possibility that this is where reduced nausea has a positive effect, marijuana and a positive effect on nausea. It's also an area of sedation with marijuana. If we think about the cerebellum, this is an area that has to do with coordination, motor function. And we know that marijuana can impair that, but there's also the possibility if you have a muscle disorder, spasticity, perhaps there's a therapeutic effect. Hippocampus, memory, this is our memory center. We know that acutely and chronically, marijuana will impair memory. And actually, chronic users who use a lot will have smaller hippocampi when we scan them. Their memory centers are smaller. Neocortex, or the cortex, looking there, we see that this is the acute effect that we commonly expect with marijuana of impaired cognition. Sometimes people will have some paranoia or other psychiatric symptoms acutely. I could go through all of this. I think we don't have time, but if at the end, if there are questions, I just want people to be aware that this is the ventral tegmentum, and this is an area where reward and addiction is kind of cited. And marijuana does activate our reward system and can be addictive, but not always, as we know. Okay, so what about public health? Marijuana and public health. Does anyone have concerns about that? John does.
Yeah.
But everyone else is okay. I have some concerns. But I have some concerns. I have questions because we now have medical marijuana, and what will be the impact on public health? We really don't know. What is this woman doing? She's smoking marijuana, and where is she? In her car. So a few months ago, I finished work, I was in my car, I was at the light at the circle, and I looked to the left, and there was a guy lighting a little marijuana, bowl in his car, and I was thinking, I don't feel good about that. I don't want to be driving around with people smoking marijuana in their car. And now we have medical marijuana, and where do people smoke it, and where do people take their medicine, and when are they impaired, when are they not impaired, and we don't really know. Is there a blood level? Do we breathalyze them? We haven't figured that out, okay? This is a great study if you want to read up on that. This is a study done by, I can't say it, by Sewell. He did a meta-analysis of over 200 studies looking at the effects of marijuana on driving. He also compared it to alcohol. First, he just looked at the cognitive effects, meaning, okay, in the laboratory when people are given an amount of marijuana, what happens to their functioning? And what he found was that people were somewhat impaired, significantly impaired, with things like increased reaction time, incorrect responses to emergencies, decreased tracking. They had difficulty with the ability to stay in lane when they were doing videos. So there was significant impairment when he did a review of many studies. However, experientially, what he found was that people do better than you would expect. Okay, there's still impairment on the road, studies have found, but people who smoke marijuana are very aware of their impairment and they overcompensate. What they do is they drive slowly. They drive really carefully. And people will joke that if somebody's drinking alcohol and gets into an accident, it'll be a high-velocity accident. People who are smoking marijuana and get in an accident have a low-velocity accident. But there's some truth to that, and it's just something to think about. Their desire to be careful does not completely compensate for their impairment. But that's important to note. Epidemiology studies, he also reviewed those, and what he found was that at very low levels of use and concentration, there's no significant difference when compared to people not smoking marijuana. As the amount of use goes up, there is greater rate of accidents, okay, and it's quite significant. In one study, it looked at 5 nanograms per ml as kind of the turning point of becoming dangerous or increasing the risk of accidents. And finally, he looked at synergy. Once you drink and you smoke marijuana together, all bets are off, because what happens is you lose that desire to compensate for your impairment. When people drink, they underestimate their impairment. If they drink and smoke, they're additively impaired but are not concerned. And so this is a very dangerous combination. And just to look at this slide, it's a little confusing, just to speak to the difficulty we will have in measuring impairment when people are smoking marijuana and on the road, okay? I'll take you through this. So let's just think about alcohol first, okay? This is blood alcohol level over time. If, let's say somebody had 3 beers, this is their blood alcohol level, the black, okay? It coincides beautifully with subjective effects or impairment. As your blood level goes up and down, so does your impairment. So you can really accurately look at blood alcohol level, breathalyze, and you see how impaired someone is. Let's look at marijuana. This is THC level, which peaks. You smoke, it's really high in your blood, and then it dissipates very quickly. Very different effect. You become impaired around the time that the THC level is leaving your body. So if we rely on THC levels to measure impairment, we're going to miss it. And so if we think about public health, how are we going to monitor that? We don't know, other than the behavior. There's no way to measure impaired or not impaired. Finally, looking at children, how will it impact? A lot of people feel it's a rite of passage, it's an herb, it's safe, it's non-addictive. You know, we hear that all the time, but if we look at national data, we see that the treatment episode data, TEDS, from the national government looks at why young people go into treatment. And the number one substance that they're seeking help for is actually marijuana, not alcohol, not opiates. So for those who are vulnerable, who start early, there's a real problem. And this looks at age of first use, recreational use with marijuana, smoking for fun, and risk for addiction. We see the earlier someone starts smoking marijuana to get high, the greater the risk that they will become addicted to marijuana. Okay? Hope that's clear. Finally, I just want to say this is, well, you know what this is, moldy bread, and we can thank Herb Malinoff for this concept, which is that, you know, moldy bread we can thank for life-saving penicillin. It's a wonderful thing. And in much the same way, we have a substance now that probably has amazing life-saving, life-helping chemicals. But, you know, we don't usually give moldy bread for penicillin. We have a certain, you know, quality monitoring, surveillance, risks, side effects, benefits. We're missing that if we just give marijuana. And I'm concerned about that. We lose a certain level of professionalism and safety in that process. And the other thing missing, because we don't have the federal government involved, is this, which is, you know, when you watch TV and they talk about Viagra and all the good, and then underneath there's the crawl that says, may cause and may do this, and may do that, or Cymbalta, and you see all the good, and that we're missing that crawl of side effects, drug-drug interactions, dangers. I think we don't know, and we've kind of avoided the usual regulatory agencies that help to keep it safe. And so we're now going to have John Harrington talk about risks and benefits.
All right, thank you for that introduction to the neurobiology. My interest in medical marijuana stems in part from my work with chronic pain patients, some of whom have come to me saying that they're using marijuana for medicinal purposes. And you know, I've thought of marijuana use as being, for example, a risk factor that might be a marker when people have other addiction problems like opioid dependence. But this got me thinking about potential benefits or therapeutic effects for marijuana, and certainly the passage of legislation about, you know, medical marijuana in Massachusetts has gotten me thinking about this as well. So one thing that's important to note is that there is limited research about the therapeutic effects of marijuana, and this is partly because research has been hampered in the U.S. By the 1970s Federal Controlled Substances Act, and John Rogers is going to speak in greater detail about this. But in short, marijuana has been classified as a Schedule I drug, which is considered to have a high potential for abuse, and essentially no medical value. The CSA criminalizes prescribing marijuana, dispensing, possessing for any purpose, including for research purposes. The only federally authorized source of cannabis is NIDA, the National Institute for Drug Abuse, and so marijuana was not available for study, and there were potential legal consequences for studying or recommending marijuana. There are some other drugs that have potential for abuse, like opioids, for example, which are certainly not risk-free in my opinion. But these other drugs are categorized in other schedules, and they're recognized as possessing potential benefits as well as having potential for abuse. So we don't know a lot about marijuana in part because of these limitations. Oops. So when we talk about medical marijuana, we're usually talking about botanical cannabis, the plant. And research has looked at the possible therapeutic benefits of smoked cannabis, of cannabis extracts that are then usually taken orally, and also at specific cannabinoids which have been isolated or synthesized, and specifically looking at cannabinoids like THC and cannabidiol that Jenny mentioned. And so, as I mentioned, medical marijuana, we often equate this with the botanical cannabis that people smoke for medicinal and recreational purposes. Part of the problem with botanical cannabis is that the potency, the purity, and the quality of it is very variable. And so dosing is also very inexact. It depends on the potency of the marijuana, the method of administration, and other factors as well. And the THC content, or the potency of the psychoactive component of marijuana, has steadily increased over time. Marijuana has been bred to have a higher THC content versus other cannabinoids like cannabidiol. So you can see from this slide that the content of THC in marijuana that's been seized has steadily increased over time. In 1975, it was less than 1%, and by in recent years, the average is around 8 or 9%, and I suspect that that continues to go up. So it is the potency has been multiplied several fold. The other thing about medical marijuana is that recreational use and medicinal use often overlap. There have been research studies that have been done where people who haven't had prior recreational experience with marijuana are excluded, in part because people who don't have prior experience with marijuana, if they are using marijuana for medicinal purposes, they often discontinue it because of the psychoactive side effects. So much of the research that's been done in medical marijuana has been done on people who have used it recreationally, and there's often this overlap where recreational marijuana use usually precedes medical marijuana use, and some people who use marijuana medicinally continue to use it recreationally, so it gets kind of confusing. So there is some research that shows that there are potential therapeutic effects for marijuana, and the strongest evidence is for severe nausea and vomiting that's often associated, for example, with cancer chemotherapy, for anorexia or wasting associated with HIV and cancer, for spasticity, specifically in patients with multiple sclerosis, and in neuropathic pain, as in neuropathy. So there is some research that supports potential therapeutic benefits in these specific areas. There is not much evidence for the use of marijuana to treat mental illness, and in fact, some of the side effects are psychiatric side effects. So although there's the potential for benefit, there are potential risks and side effects as well. And so I've listed a few of these. Some of the medical risks are endocrine disorders, reproductive disorders, pulmonary disease, maybe from smoking, premature birth, even periodontal disease from smoking. I think that's true for tobacco smoking as well. So there are definitely medical risks, particularly to smoking. And there are psychiatric risks and side effects as well. Of course, number one is intoxication. That's why people use marijuana recreationally, for the intoxicating effects. And along with those intoxicating effects come short-term memory problems, reduced focus, distorted perception of time, problems with coordination, sleepiness, and as Jenny was pointing out, that increases the potential danger for accidents, injuries, for example, from motor vehicle accidents. Until recently, it was thought that there was not a withdrawal syndrome with marijuana, that people who use marijuana heavily, if they stopped using, that they wouldn't experience withdrawal symptoms the way that someone, for example, who's abusing heroin, who stops using heroin, at a high rate, will experience withdrawal symptoms. But recently, it has been identified that there is a withdrawal syndrome that goes along with marijuana that includes irritability, anxiety, anorexia, weight loss, restlessness, disturbed sleep, and a craving for the drug. So this is a potential side effect as well, and it may increase the relapse back to dependence. About 9% or 10% of people who smoke marijuana become dependent on marijuana during their lifetime. And there's also an association between marijuana dependence and other drug dependence, and it's very unclear whether there is a causal relationship there, but there's an association. So not only risk for marijuana dependence, but possibly a risk for dependence, increased risk of dependence on other drugs. Psychosis is another potential risk. Some people experience acute psychosis when they are using marijuana, but it can precipitate psychotic disorders in vulnerable individuals. And for those people who already have a psychotic disorder, it can worsen the course of the disorder. So, for example, people who have schizophrenia who smoke marijuana have a generally rockier course of the disease than people who do not. So this is, oops.
Top ones.
The wrong thing. So this is just a little bit more detail about cannabis and psychosis. Although the risk is relatively small, it's a significant risk. Moore and Caspi and colleagues have looked at the research, and they've done some systematic reviews of longitudinal population-based studies looking at 7 high-quality studies. And the risk of developing psychosis is about 2.5 times as great in people who have used compared to those who have not. And for those people who have a specific genetic vulnerability, who have a certain genotype called COMT, catecholamimethotransferase, a specific mutation in that gene that's involved in the metabolism of dopamine, those people are at much higher risk for developing psychosis if they use marijuana. So there's this gene and environment, the environmental factor being exposure to marijuana, interaction. And there are some confounding factors, reverse causation. People smoke marijuana, become psychotic, or are people who have a predisposition towards psychosis more likely to smoke marijuana. Sometimes there's a confusion, is this acute or chronic? Is there intoxication, which is acute? And also, there is a higher risk of psychosis for individuals who use before the age of 16. So going back to the general list of potential risks, psychosis is one of them. Cognitive impairment is another, and that overlaps with intoxication. But there are negative impacts that may be lasting on memory, attention, processing speed. And these factors, or several of these factors, may be a particular issue for adolescents. 1 in 6, so like 16 or 17% of early teen marijuana users become dependent. So the rate of dependence is higher for those teens who use marijuana very early. About 3% of teens who use marijuana develop schizophrenia. It's a low rate, but it's higher than the base rate in the population. And cognitive impairment may be more of an issue for teens because of their still developing brains. Also, anxiety and depression can be potential side effects or risks of marijuana, and in teens who smoke marijuana, they have a greater risk of developing depression or anxiety even in later life. So, I mentioned before that there's smoked botanical marijuana, there are extracts, and there are pharmaceutically produced cannabinoids. And so, in contrast with the pharmaceutical cannabinoids, botanical cannabis has been referred to as a chemical slush. It contains many, many different chemicals, hundreds of chemicals, and some of those are psychoactive and some are not. And smoked marijuana contains over 2,000 chemicals, and some of those are toxic and carcinogenic. As I mentioned, and as Jenny mentioned, THC and cannabidiol have been identified as active components, and these have been synthesized or isolated. And THC may be the component of marijuana that is responsible for the increase in psychosis, whereas cannabidiol has an antipsychotic effect. It's anxiolytic, anticonvulsive possibly, and it doesn't have extrapyramidal side effects that some anticonvulsive drugs have. But as I mentioned before, THC content has been increasing, and we presume that cannabidiol has been remaining constant in marijuana that's available. So there are a couple of drugs that have been developed. One is Marinol or Dronabinol, which is synthetic oral THC that's used to treat anorexia and AIDS and nausea and vomiting in cancer and chemotherapy. There's Sesamet or Nabilone, which is similar to Dronabinol. Both of these have the same adverse THC-like side effects. Another drug that's available in Canada is Sativex or nabiximols, which is liquid THC and cannabidiol in an oromucosal spray. So the person sprays it into their mouth, and that method of administration kind of approximates smoked cannabis, and it's been used in Canada for cancer pain and neuropathic pain and MS. The thing that's different about Sativex versus smoked marijuana is the peak plasma levels of THC are much lower than if someone was smoking marijuana, and so there might be a lower risk for tolerance, withdrawal, abuse, sedation, memory impairment, etc. And so the bottom line is that pharmaceutical cannabinoids make smoking marijuana unnecessary. If people aren't smoking, right away some of the health risks are reduced. So what about cannabis in medical practice? Do the potential benefits outweigh the risks? Medical experts are very divided on this, and there are a couple of recent series of articles, sort of pro-con, point, counterpoint, looking at, do the benefits or the risks, where does the balance fall? So you can look at some of those. They're very interesting series of articles, some in American Journal of Psychiatry and then New England Journal of Medicine. And so despite the fact that there's this division within the medical world, there was a recent poll done by the New England Journal of Medicine that showed that 76% of their readership in North America is in favor of the availability of medical marijuana. Many of the people who said that they supported the availability also called for more research or an evidence base. But so there are risks and benefits. It's a point of debate, but there's broad support even within the medical community. Even those who advocate for the availability of medical marijuana, usually those experts suggest that in very specific circumstances, with very specific problems like the nausea, severe nausea and vomiting, the wasting syndrome, spasticity, neuropathic pain, for specific diagnoses like AIDS, cancer, multiple sclerosis, and neuropathy, and those are the areas where there's a demonstrated potential benefit. It's also often recommended that it be used as a last resort, only when established treatments fail. And there are other treatments available, for example, for nausea, ondansetron, Zofran for nausea, or gabapentin for neuropathic pain. When it's recommended, it should only be for fully informed patients who are in an ongoing therapeutic relationship, not some sort of superficial commercial type of relationship. So the Institute on Medicine has said that medical marijuana should be seen for what it is, a last resort. Clinical evidence shows that existing treatments for pain, nausea, and malnutrition outperform marijuana in the vast majority of patients. To substitute marijuana for more effective drugs is to practice bad medicine. So that is the opinion of the Institute on Medicine. So this is just a sort of thumbnail on the risks and benefits, and John Rogers is going to speak in detail about the legal implications of medical marijuana.
Well, we currently have in the United States 18 states that authorize medical use of marijuana. We have 2 states that have moved all the way to authorized recreational use, Washington State and Colorado. There is some belief that the marijuana movement, and there are powerful interests who are behind that, has taken a deliberate strategy, moving us from a universal prohibition, which occurred, as John mentioned, with the Controlled Substances Act in 1970, to a incremental acceptance of marijuana for all purposes, beginning with decriminalization of small amounts, moving on to medical use, and then ultimately, as has happened in Colorado and Washington, full-fledged authorization for recreational use. In Massachusetts, we've had something of that experience. In 2009, there was a ballot initiative that authorized or decriminalized the possession of 1 ounce or less of marijuana. In 2012, there was a ballot initiative that authorized medical use of marijuana. Let me step back and to a little high school civics about how laws get made, and I say it in part in defense of Representative Pignatelli here. Both the federal and the state level, there is the constitutional framework within which all laws that are enacted and enforced must fit. By and large, the statutes that govern us are enacted by our state legislatures and our Congress, if it can enact anything at all, in Congress's case, after committee study, after input from interested parties, broad statutes are enacted. And those statutes are commonly referred to relevant state agencies, regulatory agencies, Department of Transportation, Department of Public Health, to develop regulations that clarify and add detail to the effect of the law, the detail and operation of the law. The legislature generally defers to the regulators to do. In most states, there is also an opportunity for the citizens to pass their own laws, to bypass the legislature, just simply by ballot initiative pass laws. We do it from time to time here in Massachusetts. In California, they do it every Thursday, and they pass some new initiative by voter request. Those laws tend to be more crudely drafted, have more problems to them, and this was certainly the case with the ballot initiative that was approved by voters in November. DPH was given the task of making sense of this law, and it did actually a fairly good job in bringing this marijuana, medical use of marijuana, into line with other kinds of, other elements of medical practice. The regulations have key definitions in them. The original law required there to be a bona fide physician-patient relationship before the physician could authorize the use of marijuana. Didn't define what that meant at all. The regulations clarified that. There's a requirement that there be a clinical visit before any certification can be made. That's an in-person visit between the patient and the physician. There's got to be completed and documented full assessment of the patient's medical history and current medical condition, as you would with almost any other kind of medical intervention. It is necessary for the physician to explain to the patient the potential benefits and risks of marijuana use. And as both Jenny and John pointed out, we don't know what the risks really are because we haven't had the opportunity to study, but the potential a great number of risks. And then this has to take place within the context of a continuing relationship. It can't be just one-stop shopping for the patient. It's got to be an ongoing relationship, again, as you would in most other medical interventions. The certifying physician under the original law could be anybody licensed anywhere in the world. The regulations require a physician issuing a certificate in Massachusetts to be licensed in Massachusetts. In order to qualify for a medical marijuana certificate, an individual has to have a debilitating medical condition. And debilitating is defined in the regulations. It wasn't in the original law. It lists the kinds of conditions that the physician has to find, has to determine. It has to be a physician who does this, not delegated to a mid-level provider. And only if the physician determines that the individual is suffering from a debilitating medical condition, and the regulations, as did the law, spells out what kinds of conditions might be debilitating. But in order for any of these conditions to qualify a patient for a medical certificate, they have to meet the definition of debilitating. A qualifying patient, again, under the original law, could be anybody. Under the regulations, it has to be a Massachusetts resident if you're going to get a Massachusetts certificate, and diagnosed by a Massachusetts physician. The regulations also address the situation of what about individuals under 18. They must be diagnosed by two physicians, at least one of whom is a board-certified pediatrician or a pediatric subspecialist, and the individual under 18 must have, in addition to the debilitating condition, a life-limiting illness. The original law provided that individuals qualifying to have a certificate could be in lawful possession of a 60-day supply of marijuana, with no indication of how much that was going to be. The DPH has determined that a 60-day supply is 10 ounces, although it also permits a physician to adjust that amount upward if the physician documents his or her rationale for certifying a larger than 10-ounce supply. The written certification is not a prescription. It's just simply a written determination that this qualifying patient has a qualifying debilitating medical condition in the opinion of the physician, and the benefits of the marijuana outweigh whatever risks there might be. That's to be done on a form promulgated by DPH. Both the original law and the regulations make absolutely clear that no physician in Massachusetts is required to write a certificate for anybody. You can decline for any reason at all. I think that's both prominent in the original law and also in the regulations. As I said before, the determination that a patient has a debilitating condition can only be done by a physician. It can't be delegated to anyone else in the office. The certification has to be done by a physician, not delegable either. A physician who wishes to issue certificates needs to register to that effect with DPH. And beginning next July, a physician who wishes to certify must complete a 2-credit Category 1 program, CME program, that explains the proper use of marijuana, including the side effects, dosage, contraindications, as well as a component of the program needing to be on substance abuse recognition and response. As I said, you have to complete the CME as of July of next year. Physicians are required to, in certifying for medical marijuana use, comply with generally accepted standards of medical practice, and they can't delegate to anyone else in the office. And they can issue certificates only to qualifying patients in a bona fide physician-patient relationship. An important step added in the regulations is that before issuing a certificate for medical marijuana use, physicians must consult a prescription monitoring program that's operated by Department of Public Health to review the patient's prescription history. It's a requirement, an absolute requirement in the regulations. If a patient has qualified in the past but no longer has the debilitating medical condition, for reasons other than that it gets relieved by the marijuana, the physician cannot continue to issue certificates. There needs to be the initial in-person clinical visit, although follow-up visits can be by telephone, although there must be an in-person visit at least once a year if the certificate is going to be renewed beyond that time. The law, the medical marijuana law, originally had no limitation on the certificate in terms of time. So unlike any other kind of medication you might provide to a patient, this was a once in a lifetime permanent certification. The regulations have cut that back. The certificate must be for at least 15 days, but can't be for more than a year. As I said before, the physician is permitted to increase the permitted amount from 10 ounces to a greater amount if the rationale for that is included in the medical record. In addition to the two-physician consultation for a patient under 18, there has to be a conversation between the physician and the individual's parents or guardians about the neurological impact that marijuana may have on a developing brain. A physician who's going to certify for medical marijuana use is, perhaps unfortunately, excluded from having an ownership interest in any medical marijuana dispensary. Cannot issue, not surprisingly, a certificate for yourself or members of your family. You can for your employees or co-workers, but only if in the context of a bona fide physician-patient relationship. You must use the DPH form. There are a number of unanswered questions about how this medical marijuana law will work in Massachusetts. The law and the regulations expressly provide, of course, that this doesn't, our law here in this state doesn't supersede federal law. The federal government has been a little bit schizophrenic on its approach to this issue. In 2009, the Obama administration indicated they were not going to prosecute marijuana possession or growing in states where there were medical marijuana statutes in place. However, in the last couple of years, the DEA has been quite aggressive in conducting raids on dispensaries and growers that they feel fall outside the strict bounds of the state laws. At the very end of last month, however, the Department of Justice issued a memorandum to all the U.S. attorneys in the United States to tell them to refrain from prosecuting individuals in states where it was lawful to either possess or grow or dispense marijuana. That's not a change in the law. That's just it still remains illegal under federal law to possess marijuana for any purpose. This is just simply a direction by this Department of Justice at this time to U.S. attorneys in office at this time to refrain from prosecuting. This doesn't change the regulations. It doesn't change the federal law, and can be that memo can be withdrawn at any time. So it remains uncertain what impact, if any, certifying for medical marijuana use will have on DEA reaction to issuing prescribing authority generally. Certification for use also implicates other areas of the general law. You heard from Jenny and John about the impact of marijuana, the risks of marijuana use. It is clear that when you prescribe medications that may pose risks to the patient or to others, there is a general obligation to describe those risks. What kind of risks should you be describing in terms of the marijuana use? What kind of warnings about operating motor vehicles and other machinery with marijuana? That's all a bit uncertain. It's not clear how insurance companies, professional liability companies will respond to issues arising out of certification, particularly while possession and distribution of marijuana remains a violation of federal law. Remind you that the law does not require anybody, any physician, to actually certify, and you can decline to do that for any reason. If considering writing certificates, you first of all may want to check with your insurer to make sure it's covered. You have to consult the PNP, and you may want to consider at the outset setting functional goals with specific actions to be taken if those goals are not met, as you might, as you well would with other kinds of medications. And you may want to consider either the original certificate or a renewal of it on the patient's agreeing to an informed consent treatment agreement, as you would with other kinds of pain medications. Massachusetts law currently prohibits smoking in places of employment, specifically healthcare facilities, and medical marijuana is no different. The definition of smoking in our state law seems to actually contemplate marijuana when it describes smoking as including other non-tobacco products designed to be combusted and inhaled. So the hospital will it has to by law prohibit smoking marijuana in the premises, around the premises. In the event that marijuana becomes generally available in other forms, I think as patients get admitted to the hospital, we'll do some kind of medication reconciliation as we do with other kinds of medicines that they may be taking at home. There is a question about, again, because of the federal prohibition on marijuana possession, whether in fact allowing medical marijuana use within the hospital would violate the conditions of participation that the hospital signs in connection with its participation in the Medicare program. Just some information that has begun to be gathered in states that have had some greater experience with medical marijuana. In Arizona, which has had a law for some time, the greatest number of prescribers by a factor of more than 2 to 1 are, what are they called now?
Doctors of naturopathy.
Doctors of naturopathy as opposed to MDs or DOs. We don't have doctors of naturopathy in Massachusetts, and but you see that it's principally those individuals who are prescribing in Arizona. Although there are a variety of conditions similar to what we have in our law that are supposed to are qualifying conditions, the overwhelming complaint for which medical marijuana is used are severe pain, chronic pain. Colorado, which also has some longer experience than we have, the figures are pretty much the same. 94% of the of medical marijuana certificates are issued for people who are complaining simply of severe pain. These other conditions much more rarely the cause of a request for certificates. The average age of people getting these certificates tend to be male and tend to be young as well. I think that's where we are. Yes, sir.
Is there any thing in the regulations that standard causes them to assay the marijuana they're dispensing for strength and purity?
Yes.
Two questions. One, your list of conditions that it was acceptable to prescribe for, I'm trying to remember everything was on there. Fibromyalgia and neuropathy were not on there, right?
Neuropathy, there's some evidence not.
No, but on his list of what was legal, what was legal.
Regulations, no.
So neither of those were
Not
included?
specifically.
Okay. And what's your understanding of the rationale for having a certification process as opposed to having it be a prescription?
I think it largely has to do with the conflict that would exist with the DEA and prescribing rights under that certificate. It also has to do with sort of the structure of the dispensaries. So the individual gets the certificate, sends that into DPH. DPH then gives the individual a card, which allows them to go to the dispensary and get the requisite dosage.
How do we deal with the patient who is on opioids coming to the office with a certification from another physician for marijuana use? And there are already studies of concomitant marijuana and opiate use causing problems. How do we deal with these patients? What is our sort of responsibility to these patients?
Well, I don't, legally, you would be in a better position, but I would think that the physician has the right to make decisions about what medications they'll prescribe under what conditions. And so I would imagine that the physician could make the choice that they won't prescribe opioids in the context of marijuana use.
I think
So legally, basically, even though they have a certificate and they have a positive screen on marijuana in the urine, we have the option to prescribe or not.
Well, legally, I don't know.
First of all, you have the option to not certify as to marijuana.
Right.
And just as if the patient came to you on opioids and diazepines, you might want to discontinue one or the other. So too here. I mean, I think you look at this marijuana, which people have asked you to look at as simply another drug. Look at it that way and decide whether that's in conflict with something else the patient's taking.
This is a FYI for Jenny. You know, anandamide is also found in dark chocolate.
Excuse me?
Anandamide is found in dark chocolate.
And then,
Oh, anandamide, yes,
Yeah,
yes,
fine.
I know, I have a strong relationship with chocolate.
That's all.
Yes, thank you though, yeah.
It's an interesting point you make, though, because on the one hand, you could take the certification into account in terms of multiple prescribing. Do you want someone to be on both of those things at the same time? But it seems like you'd have to be a little cautious about ruling out one treatment because of substance abuse. Like you couldn't really call it substance abuse if there was a certification and
Right.
so it is an interesting question.
it's been coming up in our multidisciplinary team meetings. People who just came up last time we met, a woman who was on opiates and benzodiazepines and was receiving marijuana from a family member and using it medically and has an addiction history. And, you know, we were very concerned about this and did not feel comfortable with the addiction history and the opiates and the benzodiazepines and then the marijuana too. So we used our clinical judgment and a team to problem solve. Yeah, it's happening, you know, these complicated issues.
I noticed the clarifications of the guidelines left debilitating. Anything else that might be considered debilitating kind of on the table in terms of what you could prescribe for, which I think for psychiatry could open up some real struggles with patients who come in with complaints of insomnia and anxiety and maybe some physical symptoms as a result of that, you know, really, you know, presenting as saying, this is debilitating, this stops me from being able to function in my life. So.
Yeah, DPH struggled with that
Yeah.
and try to come up with a definition of debilitating
Right.
that would rule out that kind of situation, but like all language, it's got some elasticity to it.
Can I just make a comment in talking about anxiety? You know, what you may be seeing is patients talking about needing to smoke marijuana to avoid anxiety. And the only thing that helps my anxiety is marijuana, but we know that that's part of withdrawal. Just like if you smoke cigarettes, when you withdraw, you feel anxious and you can't focus. You smoke cigarettes, you feel better. In much the same way, marijuana will have that, people will have that sense that I'm treating my anxiety. Cause and effect. And you know, are we going to get in the business of prescribing or recommending marijuana for a problem that may be because of the substance? So.
Yes.
Yeah, quick question. So how exactly do we restrict access? So if someone has, you know, a certificate for medical marijuana, how do we know that they're actually taking it and not, you know, selling it under the table? Like, so
That's a very good question.
blood draws?
I don't know that you could do that by any kind of test. There are still, as good a job as I think DPH did trying to repair a faulty law, there are still enormous holes in it. And there's no, how would the police know if somebody was in possession of marijuana that came from a lawful dispensary or somewhere down the street? I don't know that either. I think just by having, the best you can do is by having regular conversation with the patient, make some judgment about whether indeed the kinds of goals that you set before you did the first certificate are being met, whether indeed it's creating an improvement or not, and just sort of use your own, I guess, sleuthing ability to see whether you want to renew that certificate when the time comes for renewal.
I would ask just the idea of patients coming in who have a physician who strongly supports them having medical marijuana. They're coming in for treatment of pneumonia or maybe some aspect of their cancer or some other medical problem. How are, you know, the medical people, the hospitalists and others thinking about that, managing, you know, this patient comes in, I want you to do a med reconciliation, keep me on mind. We were saying you can't smoke in the hospital, so you rule that out, but if they're getting some other form in a compound, just curious about how people are thinking about managing that.
Well, we talked about, you know, Marinol as an option. It's very expensive and it has limited label, you know, on-label approvals, but we talked about that.
I think to the extent that it's being taken to address chronic pain, we can find simply alternatives that don't conflict with whatever else.
see that in the graph you showed that mostly it's being used for chronic pain. Is it that the government is trying to address the public health issue with opioids in chronic pain that has come up? Every 90 minutes, one person is dying of overdose. Is that the movement that marijuana is less, compared to opioids? If there's no overdosing, dying from marijuana, is that a move to go that way, or?
I suppose it would be a positive thing if there were a movement away from more dangerous pain medication to marijuana, if that is indeed less dangerous. I don't know that that's the case, though. I don't think there's any indication that people are consuming fewer narcotic pills and smoking more joints.
How long do the therapeutic effects last for patients?
With marijuana?
Yeah.
So peak effects are very rapid when it's smoked. Within a half an hour, there's a peak effect, and then it dissipates over the course of maybe 3 hours or so.
You have to be smoking all the time.
Yeah, I was gonna say.
Yeah, you have frequent smoking.
Some people who use marijuana medicinally smoke or consume very small quantities over extended periods of time. Some people do that to minimize the psychotropic effects while trying to gain the beneficial therapeutic effects.
And what's the route to administer to children? Is it smoking?
It can be vaporized and it can be ingested. I think that people are still learning about it. It's unusual. I think one of the slides that we looked at had a number of young people, under 17. It's actually very rare. It does exist, but it's fairly rare for underage people to get marijuana. But you don't have to smoke it.
I wanted to thank John and Jenny and John for a really outstanding presentation. I mean, it was comprehensive.
I did too.